Like my fellow panelists, I looked at the title of this session, and I didn't get it. But I'm going to try to get at it. It says, implications of healthcare reform, no will be heard. So no could be a couple of things. I'll set up two sides of a coin, and you tell me if I'm even close to the ballpark. No could be, as we just heard, an insurance person kind of sticking their perspective into shared decision-making and saying no. But I kind of think that what we're trying to get at also today is that the patient may say no and might want to have no respected. John Fox, tell us about patients saying no, or you saying no. You're a payer guy.
Yeah.
How does it, do you say no first? If they say no, are you allowed to say no or yes? How does it work, John?
My longevity is dependent on saying no as few times as possible. I think as a payer, we don't want to be in the position of being interposed between the patient and the provider. We can't expect that patients are always going to make rational decisions, but we can certainly expect that patients be afforded the opportunity to make their choices known and to have their choices respected. In that circumstance, I can't say no, and I don't want to say no. But I think the challenge today is that all too often, patients don't have the opportunity to make their choices known until it's too late, until it is the very end of life, or when they can no longer speak for themselves. So I think that as payers, we certainly have to demand that patient preferences and choices being made known, that they be given qualified people to help them go through those decisions. The Conversation Project through IHI, Respecting Choices from Gunderson Lutheran are just examples of ways that patients and their families had the opportunity to make those choices known. And I think fundamentally we have to find a way of paying for those. As the person from NCQA said, well, we don't know that these conversations are going on, and we have to find ways of paying for the things that we value.
Got it. But when patients say yes, sometimes you still have to say no. Right, John?
Well, that's a discussion between the health plan and the provider. I think too often providers get put in a difficult circumstance of being asked to provide futile care. But I think most of those conversations where we have to say no are between the provider and the payer, and we don't want to put patients in the middle.
Okay, fair enough. Ira, you work for a mid-sized little outfit that pays for health care, and so which side of the no continuum are you here?
Well, I think both of those no's happen, and I think I agree with John about it's always better to have the no discussion between the provider and the payer, because the patients are often, and this is not their fault, not fully informed as to what it is that's requested and what the repercussions and ramifications are. One way in which we could make that better would be to take the salient statement made in the previous lecture that said how people feel about care affects utilization. And for them to feel anything about care, they have to understand care, and there has to be a little bit more transparency. So it doesn't mean that we're going to take all of our patients and turn them into amateur oncologists. It just means that they should have access to a little bit more understanding about what is going to happen to them from the beginning, the middle, and the end, whether it's incurable disease, long-term survivorship, or midterm remission. I think how you say no, or when you say no, or if you say no, is tempered by who are the people you're dealing with and what it is they want that you're saying no to. Because if they really understand what's going on, saying no doesn't really happen very often.
So no is one answer to, or one option, if you will, to a presentation of information, of trade-offs, risks and benefits and so forth. And whether or not a patient can even get to the point of providing an informed no, or even yes, depends on the ability to kind of offer the information in the right place, the right time, the right way to convey it for that individual patient.
Yes.
So no is kind of a subset answer to that.
Well, and
John?
It's interesting because the evidence shows, and it was mentioned earlier, that when patients are fully informed, they tend to be less aggressive than their physicians. There was a study published by Janice Weeks last October that showed that 81% of patients getting chemotherapy for metastatic, incurable colorectal cancer thought they were getting curative chemotherapy, and that
percentage, say it
81%.
81%.
Yeah, and 69% of patients who had metastatic, incurable non-small cell lung cancer thought they were getting curative chemotherapy. So if patients don't know what their prognosis is, and I think this was said earlier as well, how can they make rational choices? And the evidence suggests that if they knew they weren't curable, they'd make different choices. They'd say no to aggressive therapies.
Got it. Dr. Fendrick.
So it's very interesting. When does no really mean no? And many of us have said that to our kids, and like Bill Clinton, and what is it? So the first thing is, not that I support or defend the payer industry. The payer saying no doesn't mean that the patient doesn't get the therapy. They could always use their own money. And as we talked about earlier, the shift to high deductible health plans, this is happening anyway. But I really would prefer the discussion from no, which is actually pretty rare, as John points out, to shift from easier to get and less to get based on the evidence. Since now, almost all these cancer therapies, and specifically in the specialty pharma arena, access to patients in terms of their benefit design is completely equal, regardless of you have a intervention that cures a cancer 90% of the time, or one that at best will extend life by a few months. So so when we say no, and people ask me, Cliff, as you know, I've been called a death panelist. This issue had come up last night in our discussions at the reception. I think that is our responsibility, all of us stakeholders in the room, to ration harmful care. Right?
Ration harmful care.
So care that is known to be harmful, that is administered in a number of situations. As Ms. Berman brought up, most of these things, as outlined by the Choosing Wisely initiative, are somewhat rampant, not only in oncology, through the screening, treatment, and monitoring processes. Let's focus on the no on those things where the evidence suggests are harmful, and then get into a longer dialogue on easier or harder for those things for which there is evidence, but not definitive, always yes and always no, which all oncologists know are extraordinarily rare.
Okay, but speaking of oncologists, when patients do voice their preference, easier, harder, yes, no, how equipped are oncologists to actually listen to what the patient said, if it's a no, for example, and proceed accordingly? If the oncologist says what Amy Berman's second oncologist or first one said, this is what we're going to do, that did not sound like a person who was ready for no at that point from you, I don't think. Mark, are oncologists equipped to deal with that? Are they even listening?
Well, there are a lot of oncologists in the room who could answer. All I could say is there's no one oncologist. Like in Amy's situation, there are one that are more willing to listen, and others, I think it's, and I don't want to just pick on oncologists. If you look at any of the literature regarding specialists, right, they are trained to believe that their interventions are helpful. Whether the evidence is strong or evidence is weak. And it's very interesting when you compare interventions such with grade A evidence compared to B, C, even D, it's remarkable the variation you'll receive from clinicians in terms of their willingness to push patients to get them done.
Okay, so John and then Ira, from your standpoint, your sectors, what are you doing to enable patients to be more informed and get to know when it has to be that? What different sorts of things, John, are you doing a priority to get to that point and support that?
Yeah, I say this at least twice every day, so people have heard me say this before. There's a gap between what we say we want to do and what we actually do, and we have to fill that gap with good process. Oncologists say they want to talk to their patients, they want to know their goals of care and their preferences, but they don't have good systems. So one of the things that we're doing, is helping groups, along with partners like COA and Ion Solutions and PRM, to create systems of care within practices so it becomes a routine. It becomes expected that we have these conversations rather than the exception, and we have them early rather than late. And then second, we're paying people to do that. We can't say this has value and then not reward that behavior.
How does that work? How do you set it up to pay them to do that?
Well, there's a billable code for advanced care planning, and we reimburse physicians, and we in fact reimburse physicians for having these conversations with Medicare patients as well.
So that's where it's discussed and that's where it's reimbursed.
Yeah.
Ira, same thing, Aetna?
Well, we also believe in setting up systems of care, because if you can have people in a pay-for-value arrangement where you show them the information about how they treat people, you can get them to take one-off discussions that could be highly variable in the actual discussion event, in the minds of the clinician, they might say, no, every patient gets a particular standard of care. We never deviate. And yet, if you don't feed back information to them about what they're doing, there's really no ability to figure that out. So by being in a pay-for-value arrangement, and as John said, you have to pay people, but you have to show them the information about how they're treating patients. That has a disciplining effect. It does, as Mark said, ration harmful care in some manner. On the patient end, we're looking at ways to have patients be more engaged, not be a passenger in the journey. That's really hard to do, but I think we're launching some pilots in 2014 that may prove that if you have people early on engaged in a discussion with someone who's trusted and acts not as I'm the nurse from the insurance company, but I'm someone who's an adjunct working with your doctor's office, that might be able to wrap people into a more transparent discussion about what they want. And if they understand what they want, no will probably be heard less.
Okay, so take it up a level now. You're talking about certain trends and so forth. What impact, if any, is healthcare reform, other structural changes in the healthcare system and payment and delivery? Is this enhancing or depressing the opportunities for patients to exercise that will? Ira?
I would say it's throwing them a life jacket, because with healthcare reform, you will have changing networks, changing co-payments, changing co-insurances. And if there's no mechanism to have people more engaged in their care, especially in cancer care, which is complex, the system is not integrated, it's fragmented. If people don't have a way to make their way through the system and understand what they're going to pay, what they're paying for, it will be a degradation in the care that we have today, which is not optimal.
So a degradation even relative to now.
Yeah.
John, do you concur?
Well, I'm not sure that I can answer this. I think ultimately we need to remove any barriers that exist to ensuring that patients have an opportunity to express their goals of care. Along Mark's lines of value-based benefit design, we've made those conversations free to patients. And I think ultimately we'll drive down the cost of care if the evidence is correct, if we are more in tune with what the patients want, and we create systems of care that ensure that those voices are heard.
Okay, so Mark, then, what policies or provisions flowing from healthcare reform or elsewhere will enhance or depress the ability for patients to make these decisions? Are there policies that provide greater choice or support that?
Specifically as it pertains to oncology, as well as many other parts of medicine, one of the most popular aspects of the Affordable Care Act, Section 2713, which is the one that includes value-based insurance design elements, which states that services with A or B rating from the U.S. Preventive Services Task Force, so many cancer screening programs, not all of them, are now mandated in non-grandfathered plans to be free of charge to beneficiaries. And so no woman will ever pay for a mammogram over the age of 40, colorectal cancer screening over the age of 50. The health plan has the option what to do for prostate cancer screening, which now has been deemed by that same organization, the U.S. Preventive Services Task Force, as harmful. Yep. And in most commercial plans currently, coverage is equal for A services and D services with those examples, which suggests that there is still a lag around using evidence-based decision-making regarding coverage for cancer screening. This idea of clinical nuance regarding what the benefit design should be has been driven not by health plans, nor by the ACA or federal decision, but the private sector, largely employers, to say, I want my cancer care post-screening to have this equal level of clinical nuance. Easy access to services, like John says, whether it be treatment planning or evidence-based interventions once the diagnosis has been made, and potentially make it a little more difficult for those services that either physicians or patients are clamoring for when the evidence is not there, or even worse, when the evidence is there that it doesn't work.
You tossed out this phrase, clinical nuance. I just don't want to gloss over that. Is that like a term of art these days? To what does it refer?
Well,
clinical
I told
nuance.
Brian Haug that I should have trademarked it, but it's a term to explain to not a sophisticated audience like this. The main issue that most benefit designs, public and private plans, basically have a one-size-fits-all system. All doctor visits cost the same. All drugs in the tier of the formulary cost the same. Every diagnostic test costs the patients the same out of pocket. We all acknowledge, and all of our patients and almost hundreds of thousands of ARP members understand that medical services differ. That prostate cancer screening does not have the same level of evidence of colorectal cancer screening. But more important to this audience as we move forward the idea of clinical nuance, not only are services high or low value, it depends on who is getting that service, when in the course of illness they're getting that service, who provides it, and where.
So that's comprises the nuance.
Right. So colorectal cancer screening, as many of you know, an area of interest of mine for many years. First-degree relatives of colon cancer sufferers should be paid to get colorectal cancer screening. And there's very strong evidence to suggest that not doing that is not only harms people, but actually costs extra money. It is now the law of the land that people over the age of 50 get free colorectal cancer screening. But if you are motivated by Katie Couric's Today's Show colonoscopy, but are 25 years old and don't have a family history, you should not have that test covered, and you should be fined $500 for taking your mother's appointment.
I'll take that under advisement. So, John is a payer, and then Ira, does clinical nuance, these kind of fine gradations figure into your decision-making, your policies?
I would like to say yes, but it's challenging.
How so?
Well, I'm just thinking, for example, about drugs for cancer therapy. There may be drugs that are more effective in one cancer versus another. And yet, for us to be able to say, for one indication you're going to pay more, and another indication you're going to pay less would be challenging. And so I don't think it's impossible to create clinical nuance and benefit design, but I think the challenge is really, could you operationalize it and could you explain it to people? And that's where I think we'd have a challenge. I think some of the examples that Mark cites are relatively easy to understand, but to implement those would require a level of oversight that we don't have today, and we probably can't afford.
Really quickly.
He needs a rebuttal.
No, not rebuttal. As Amy pointed out, one of the ASCO choosing wisely low-value interventions is the use of targeted chemotherapy without biomarker testing. And we know I've innovated. This is something that Lee Newcomer has been talking about for a decade. I am more than happy to pay for targeted therapy if the target is there. The idea that we should pay for targeted therapy when the target is not there and ASCO says we shouldn't do it, these are not hard. I'm pushing Ira and John and the other payers in the market. These are things that we must do to start.
Well, and those things we can do if it's a bimodal or a yes or a no. Those we can do, but having a graded coverage is a little more challenging to implement.
Ira, speaking of oversight, you have quite a bit of it. So,
I have to oversee Mike.
yeah. But can you kind of put this in place by Monday, Ira? No, really, seriously, how do you kind of cope with this, the push for the nuance here in the between, the bimodes?
Well, I know the actuarial people at my company will love this answer because it's a brutal one, but Mark and John are correct in how difficult it is to gravitate towards a system that gets you that nuance built in. A way to do it more quickly, not by Monday, is to measure who is including some elements of clinical nuance in their practice. Obviously, people would have to mutually agree about what those are, and those who are not are out of the network.
Yeah.
I see this is when your actuaries thank you.
Oh, they love me.
Okay.
Well, they usually don't love me, but
Okay. For that,
You know-
John, quickly on this. Yes, John.
Well,
quickly.
I just, this idea of nuance is interesting because take that from the patient's perspective. Clinical nuance, Lily Shockney at Johns Hopkins says there are 4 things that patients want. She probably says more, but those are all I can remember. A, they don't want to die in the hospital. B, they don't want to be in pain. C, they don't want to be a burden on their families. And D, they don't want to leave their families broke. And those are great outcome measures because I think we can measure all of those if we wanted to. But that's the kind of nuance because every patient is different and what their preferences are and what's important to them are going to be different. And those are the types of things that I wish we had more attention around because I think we wouldn't have to have benefit designs to address these issues if we were more effective at answering
All
them.
right, now and that helps. Now let's just if we take this maybe a little too far, how, Mark Fendrick, since you were pushing on this, because you were pushing on some so-called evidence-based legitimate no's, how do we protect against the downside risk of no leading to underuse?
Right. So,
Help us with that.
So that's
briefly.
that's where clinically nuanced value-based insurance design comes in. So the evidence comes to bear, and we leave that up to ASCO and the other thought leaders the same way we did identifying the low-value services. And you start to see this shift away from a one-size-fits-all, where the good stuff and the bad stuff cost the exact same, to where the good stuff starts to cost a little less, and the bad stuff starts to cost a little more. This is not no. This is easier and better. And as Ira noted, the actuaries love this, because the more you, instead of having all specialty pharmaceuticals cost 20% coinsurance, you have these ones that Scott Ramsey and Peter Bach would pick as the no-brainer, life-saving. These should be free or close to free. And the interventions that John says these should not be given under any circumstances should be 21% or more. And as this dialogue has happened in the small molecules, where insulin and statin and smoking cessation drugs start costing less, and toenail fungus drugs and male pattern baldness drugs start costing more, this is the movement that's happening regarding clinical nuance.
But Mark, would you say then that cancer drugs that are used only to treat metastatic disease should be reimbursed less, and that patients should pay more because they don't cure disease, they just prolong life, and sometimes by very, very small amounts?
So
There's
very briefly,
quandary.
that is VBID 9.0. Right, no, and I agree that
Yeah.
I would be happy to have a discussion with you to have that dialogue. The fact that now that drugs off-label, 9th round of salvage chemotherapy, have the same coinsurance for a drug that cures cancer to a targeted condition 90% of the time should not cost the same.
Okay, that was Mark Fendrick's last word.
Exactly.
John's the penultimate. Ira, any last word on the nuance here? How you're pulling it off for that, or might you?
Well, I think if we have an ability to understand clinical nuance from a quality metric reporting perspective at the physician level, we can then help patients by, as Mark said, make it easier or better through maybe not you're in or out of the network, but maybe you're preferred, you're non-preferred. And so the out-of-pocket expenditure is greater for those who are not preferred, and thus we have a nuance that's not absolute, but it does drive decision-making.
So then, Ira Klein, John Fox, Mark Fendrick, what they actually did accomplish for you just now is they brought some insight and enlightenment to a session title that left me wondering. They told you it's not about the no, it's the nuance. And with that, I want to please join me in thanking this wonderful panel. Thanks for that.
Thank you, John.